And thanks for the invitation to speak. It's the third Visible Heart Lab talk in a row here, so hopefully we're not tiring you out. I'm Ryan Nadybal, one of the PhD candidates in the lab. Thanks for the invitation. It's been great to be here over the last few days. So I'm going to be talking about a preclinical model for closed chest tamponade and how we developed that, and some of the electrical and hemodynamic monitoring that we have found as we've developed this model. So these are my disclosures. So cardiac tamponade is the filling of fluid into the pericardial space. This could either be by infection, other fluid, or in a traumatic injury, it can be blood. The pericardium is a very non-stretchy tissue, and so as blood or some fluid fills that space, it pushes back on the heart and inhibits it from functioning properly. This can present clinically either through Beck's triad or pulsus paradoxus, kind of symptoms that have developed as the pericardial sac is filled, and then diagnose confirmation with echocardiogram, and you can visualize this easy. If this continues to progress, patient, the cardiovascular system collapses, and it's an emergent case to drain the fluid and have to go and repair if there's an additional bleed. So kind of this is the motivation for this study is, can we look at parameters that are less symptomatic? What can we measure in order to see the onset of tamponade in the case of a post-procedural cardiac surgery or procedure that we can measure and not have it be such an emergent case to fix or to resuscitate. So some previous work has been done in the preclinical space with tamponade. This was done using an open chest model. So what they would do is they'd do a medial sternotomy, spread the rib cage, and stick a introducer and catheter right into the pericardium. And they get a good seal, and they could fill the pericardial space with fluid. However, being an open chest, you don't get the option to have a 12-lead EKG. So in wanting to use EKG parameters, we first set off to say, could we develop a closed chest model? And if we can do that, what measures can we use in order to see the onset of tamponade? So this is our prep for the model. We use Yorkshire swine in the laboratory, about 60 to 80 kilograms, so that the heart is about the size of a human. We will first, once we bring the animal in and intubated, we'll get access through the neck so that we can get into the vasculature and cannulate and put catheters down into the heart. So in this case, we're using a pressure volume loop catheter to look at both left ventricular volume and pressure. We're also looking at blood pressure through an arterial line in the leg. And then we have a 12-lead EKG. And before anyone's too concerned about the placement of the electrodes, the swine heart is in a little different anatomical position than it would be with a human. The swine heart is straight on the midline and rotated so that the left and right ventricles are a little more lateral to each other. Then we also will do a subxiphoid access cut down so that we can get good echocardiography windows to calibrate the pressure volume loop catheter. And this is where we are accessing the pericardium to introduce the fluid. So kind of the experimental setup, we get all the animal prepped, and then we'll use warm saline and inject that into the pericardial space. Done this now in 4 animals and doing increments of 50 milliliters into the pericardial space. And we've gotten up to 200 milliliters. So I want to show you a little bit. The next couple of pictures are from the procedure. So just a forewarning here. So on the left is a video. Again, we've done a cut down to the xiphoid process, which is being held up there in the center of the screen. We've cut underneath and through the pleural lining, and you can see the heart beating in the pericardium there in the background. we'll use a needle and stick the pericardium, put a wire in to make sure we're in the pericardial space, and then we can put an introducer and catheters down in. And then the image on the right is after we've opened the chest, we've left the catheter in place, what this setup looks like. Under fluoroscopy, this is another view we have here. This is the catheter coming into the pericardial space. From here, this is the pressure volume loop catheter, the pigtail sitting down in the apex of the left ventricle. And on this particular day, we were also doing some other EP studies. So we had a couple decapolar catheters in the right side, and then across the front of the chest, we have the precordial leads. So when we start to introduce the pericardial fluid, we'll use a little bit of contrast with the saline so we can start to visualize the heart and the pericardium. So you can see in the first injection, there's very little space in between the pericardium and the heart. And then just after 50 milliliters after the first injection, you can start to see a little bit of more space start to develop between the heart and the pericardium. And then up to 200 milliliters, you can see this, especially down around the apex, significant amounts of distance between the heart and the pericardium. So now look at a little bit of results here. So our pressure volume loops, kind of our view of what's going on right inside the heart. And kind of as we expect, we're having a decrease in pressure, and we're not filling the heart as much because we have this external pressure pushing on the free walls of the ventricles. And with less filling, we see less strong contractions, and so we're getting less pulse generation. On the right-hand side is a comparison of the left ventricular systolic and diastolic pressures in the solid lines compared with the arterial line blood pressure, systolic and diastolic, there in the dotted lines. So we see that both the systolic pressures track, the arterial systolic pressure decreases along with the increase of fluid in the pericardium. But you can see you have to get up as there's a small decline initially, and it takes a pretty serious amount of volume before you're going to start to really see a crash, and it progresses very rapidly from that point. Also looking at the cardiac output, stroke volume, and heart rate. As we're not getting as much stroke volume, the heart rate does go up to compensate to try and keep the cardiac output sufficient. But once it progresses fast enough, it just tends to crash very quickly. And you can imagine what kind of emergent case that would be if this happens, in the ICU. So there's a couple of signatures here. You start to see systolic pressure declining. You start to see heart rate increasing, but maybe not as significantly or suddenly to notice. Looking electrophysiologically, you can see there's some general trends and deflections in the tracings. However, when plotting the data, there's lots of noise. Looking at the error bars, there's lots of noise in the signal. So making this challenging, like there might be some underlying trends that things are going on. I just want to highlight a couple leads, V1, V2, and V4. When normalizing that data, the amplitudes in reference to the baseline value, even after 50 milliliters were injected, there was a significant drop in amplitude. And so this kind of gives us a different idea that maybe something within the in the EKG could be an indicator of something's going wrong quickly, and we can intervene sooner rather than having to wait till it's an emergent case to do so. So going back and comparing the systolic arterial pressure to those pericardial leads, there's quite the change from one to the next. And as this goes up, there's more noise in the signal, making it a little more challenging to kind of watch that trend over time. So conclusions here. A closed chest tamponade model is possible, and it allows us to collect that hemodynamic and electrophysiologic signals. The EKG signals may be affected by the tamponade earlier than arterial pressure, and that the heart rate also increases with tamponade to help offset the decrease in stroke volume. So like I said, this has only been done in 4 swine so far, and so additional sample sizes would really be helpful to help us decrease the noise or to have more confidence, increase the statistical power to draw some more solid conclusions, and then hopefully to bring this back to the clinic so that we are avoiding emergent cases and patients are not having to suffer from having to do reduced sternotomy or any kind of, we'd avoid any post-procedural complications later on. So thank you, and I think we'll take questions at the end.
Yes.
Okay, thank you.